There we go. Okay, we're good. So when you were previously, noted to have lymphoma, and this is now dating back to like 2014, it was this subtype of lymphoma that we call follicular lymphoma, which is in general classified as a slow-growing type of lymphoma that is very treatable, but unfortunately incurable. And usually the typical trajectory of this disease is that patients may present with this and then may need treatment, and we institute treatment like the bendamustine or rituximab that you've gotten back in 2017, and it puts the disease in a good state of control. And then we monitor patients, and then in the future the disease may rear its ugly head again and necessitate us going back to treat the disease again with different therapy. And in your case, back in 2019, the disease recurred and became an issue, and you received the R-CHOP therapy for 6 cycles. The expectation with that therapy is that that treatment would put this disease into a remission. And much like we were in 2017, we would be able to enjoy ideally many years of not receiving therapy and not having to worry about the cancer. Unfortunately, in your situation, the R-CHOP therapy did not lead to a remission of this disease. And the disease has in fact been still present for several months now. I know that you and I initially met in November. And I know based on insurance issues and so forth, it's taken an unfortunate amount of time to get to where we are today. But what we were able to do with the biopsy is confirm that this is in fact still follicular lymphoma that has been persisting now for the past 6 months or so untreated. And I think a lot of that is playing in with how you're feeling today. Wanda, I think the fact that when we were talking on the phone last week and you were relating to me how tired you are and how your energy is zapped and everything like that, I think that's really a direct manifestation of the cancer itself, and it means that we need to do something about the cancer. There are a number of different options in terms of how to treat the cancer. There are options that are potentially associated with a hospital stay and treatment in that context, but there's also other options which may be able to be provided through your local oncologist, to where you could get treatment there, and it may consist of pills in combination with an IV infusion. So there's a few different treatment approaches. There's not necessarily one that is superior to another one. There's many ways of approaching it. One of the ways that I would approach it would be a standard regimen, meaning a regimen that is FDA approved for this disease, and is something that can be provided by any oncologist, including myself or your local oncologist. And this would be a pill, which is a chemotherapy pill, which is taken at nighttime for usually 3 weeks in a row with 1 week off. And this regimen is usually continued for 3 weeks on, 1 week off for at least 12 months. Okay? It is given in combination with an intravenous infusion of a medicine. This intravenous infusion is a drug you've seen before. You saw it with the bendamustine, and you saw it with the CHOP therapy. It's an antibody-based therapy that attacks cells that basically have this marker on them. So it only attacks the bad lymphoma cells. It doesn't do damage to the other cells. And both together, this IV drug and the oral drug work in concert to knock down the cancer. And I think it has a good chance of working in your situation, and I think it's a very reasonable option. There are also, though, the possibility of enrolling in a clinical trial which evaluates sort of a new or novel treatment, which is known as CAR T cell therapy. And this is a different treatment approach that basically works to retrain parts of your immune system to recognize and attack cancer. And we have recognized that a significant proportion of patients, in the literature at least, respond to this treatment and may be associated with a durable disease control for a subset of patients. And so that is also a treatment option which I would say would be possibility in your case. There are pluses and minuses to each of these different therapies, and I apologize. So the easiest, if you were to ask me, what is the easiest option for me? What is the one that's going to be associated with the least doctor's visits, the least hospitalizations, the thing that I can get done locally that I don't need to come to the University of Chicago for? It would be the IV infusion in combination with the pill. But if you're interested in exploring other options, which may be a little bit more, I would say, logistically challenging with the need to come here at the university more frequently, we certainly have those options, and I think they're something that would be intriguing and may actually end up controlling her disease very well. But again, that's the downside of those type of treatments, is they may be very, very effective, but usually patients need to be hospitalized for a week and a half or so to get the treatment. Versus the pill in the IV treatment can be done all as an outpatient and does not require a hospitalization.
Downsides to the pill?
The pill, in some instances, can increase her risk of having blood clots. And so we make sure that patients are managed on aspirin in order to reduce their risk of developing a blood clot, but it doesn't negate the risk. It is still there. There is about 15% of patients that may develop a rash associated with the pill. Usually that rash is responsive to steroid therapy or responsive to us dropping the dose of the pill, so it's not something that would preclude her from getting the medicine. It may be associated with a decline in blood counts, which may also mean we change either the dose or the manner at which we're administering the pill. The pill is generally taken at nighttime, and that's because sometimes it can make people a little bit sleepy. So if you take it at night, you're already going to bed, not a big deal. The intravenous infusion is a medicine that you've had before, and I think you probably will tolerate well. Again, it only attacks the cancer cells, but we sometimes do see where there is risk of developing an infusion reaction to the intravenous medicine. And that can present with things like fevers, sometimes shortness of breath, scratchy sore throat, decrease in blood pressure, or rash. But generally that happens during the infusion. And if we stop or slow down the infusion, usually those symptoms resolve after about 15 minutes, and then we're able to restart the medicine. That usually is only a risk with the first dose of medicine, though, and it's not something seen with the subsequent doses. Again, I think these are both reasonable options. The easiest one is certainly the pill and the IV. And I could get in contact with your local oncologist and discuss that option, and they could be able to, ideally within a week or so, get everything set up and get you started on it. I think it will, ultimately help you feel better, which is what we all want in this situation, is for you to feel, back to your old self. I think a lot of the symptoms that you're experiencing are from the fact that you've had lymphoma growing now for 6 months that we haven't done anything about.
So, just in remission, there is no cure known yet? Correct,
not any cure yet. But each of these therapies can provide us some good benefit. The trial, the treatment that I was discussing in relation to the one that would require the hospital stay and everything is an experimental therapy, meaning that it is not FDA approved, and it is only available in the context of a clinical trial, which is investigating the treatment. And so we can't really necessarily speak to exactly how effective that treatment is going to be, but within a class of therapy, we think that in general that treatment is very effective. And in probably about 70% of patients, it does lead to a complete remission, which in many instances can last years. So that's the one benefit of that. But of course, it's a little bit more of, short-term intensive follow-up and everything, but you may have, long remission duration versus, the pill is seeing us at least on a monthly basis for the first part, and the first month of it actually is on a weekly basis.
So I will have to take the pill every week.
You would take the pill for 3 out of 4 weeks in a row. So basically, if we were to start the first month, let's say we start February 1st, you would take the pill February 1 through February 21, and then you would be off the 22nd through the end of the month, and then you would get started again on March 1st, and you would be on it for 3 weeks in a row. In general, the pill is well tolerated. I have, for example, one of my other patients I saw earlier today is 79 years old and is on this pill and the IV, and she's been on it for 14 months now and is doing well.
So, the clinical trial, how long will I be hospitalized if I go there?
The clinical trial, you would likely be hospitalized for probably, I would say, about 2.5 weeks or so for the first cycle, and then the second cycle you would be hospitalized for probably about 4 days. The rest of the therapy after that is done as an outpatient. The way that the clinical trial is sort of operationalized, and I'll kind of speak to that a little bit, is we first start by collecting your T cells, which are a part of your immune system. Your T cells are generally the sort of the big master controller of your immunity, and they're the ones that are responsible for fighting viruses and bacteria and everything else, but they also have a heavy hand in evaluating and killing cancer cells. And in your instance, we know your T cells haven't done a great job of dealing with the cancer, which is why we're now in the situation we are. But we've recognized that if we're able to extract your T cells and then re-engineer them to identify and attack cancer, that can be very effective in patients. And so this generally starts with us collecting your T cells, which usually means that we put an IV in each of your arms, and we run your blood from an IV catheter in this arm through a machine, which is very similar to a dialysis machine, if you're familiar with what dialysis is. Mm-hmm. Dialysis is basically where it cleans the blood and removes all the toxins, and everything that's not a toxin goes back to you through another line. This takes all of your blood and runs it through this machine, and everything that's a T cell gets collected in the machine, and everything that's not a T cell, like a regular red blood cell or a regular white blood cell or a regular platelet, comes back to you through the other catheter in your other arm. That process takes approximately, I would say, 3 to 4 hours. Then the T cells that we collected are shipped off to a manufacturer where they are processed and basically manufactured into CAR T cells. And that takes approximately 4 weeks or so to happen. During that 4-week time period, we can treat you with other medicines to kind of knock down the lymphoma so you're feeling better while the CAR T cells are being produced, though. Then, once the CAR T cells are ready, we treat you with 3 days of chemotherapy. That chemotherapy, though, isn't really, the intention of it is not to attack the cancer. The intention of the chemotherapy is actually to make a very fertile environment for the infusion of these CAR T cells. It's almost like if you are going to plant a garden, you want to till the soil and make sure that it's a fertile environment for when you plant your plants in there so they have a chance of growing. This chemotherapy kind of changes the immune system to allow these CAR T cells to do their job a lot better. After the infusion of the chemotherapy for 3 days in a row, we infuse the CAR T cells. And patients are then in the hospital for approximately 10 days or so after the CAR T cell infusion to evaluate for potential side effects of that treatment. We then see patients here at the medical center on a twice a week basis until 1 month after the CAR T cell infusion. So if she's in the hospital for 10 days, we're seeing her as an outpatient for approximately 20 days on a twice a week basis. And then the follow-up kind of spreads out a little bit more going on afterwards.
Now, that's not FDA approved. Would it be covered by the insurance?
Well, that's something that we'll certainly get insurance approval for. When she was referred to me, she was referred for consideration of advanced treatment options, is what they call it, which would be things like CAR T cell therapy and stem cell transplant. And so we would need to investigate if that is a benefit in her case, but by and large, yes, it should be. And it would be something that's covered. But we would want to get the ball rolling on looking into that sooner than later. What I can do if there's interest in at least exploring that as a treatment is to provide you the consent form for this clinical trial, which kind of goes through the whole operation of what it is, what the drugs are, what the potential side effects are, and so forth. There are a couple unique side effects to the CAR T cell therapy. One of them is a side effect that we see in patients that sometimes have viral infections, for example. If you've ever had a viral infection like the flu or anything else like that, you may develop things like a fever or muscle aches and pains, sometimes decreased energy, sometimes shortness of breath, lack of appetite, lower blood pressure, things like that. Those are all things that happens to the body because the body is trying to fight the virus. And that's basically a manifestation of the body sort of trying to activate its immune system and to kill the virus. Mm-hmm. That same thing happens when we infuse these CAR T cells to where they all of a sudden become active and they start attacking the cancer. And that can sometimes be associated with some toxicity, but we have medicines to be able to kind of dial in the immune system a little bit to where it's not too serious or severe. One of the other things that we sometimes see is another toxicity that's called neurologic toxicity. This is less frequent in patients, but it can present with things like sometimes confusion, trouble finding her words, tremor of her hands, and in very rare instances, seizures. That is also a very manageable toxicity with medications. In general, both of those toxicities, if they were to happen usually between the day of infusion and 14 days after. And if they are to happen, they usually both become relevant and resolve within that time period. So these are not necessarily long-term toxicities where 6 months down the line she's going to have issues with low blood pressure. They are things that happen at the time of or around the time of infusion.
And she already has naturally low blood pressure.
And that's something that we would monitor in her case and make sure that we're managing it appropriately.
So if I don't want to stay in the hospital, which one would you suggest?
If you're not interested in the hospital, then I would say that the chemotherapy pill in combination with the IV infusion would be the one I would suggest in your case. And that is also one that can be done locally.
And she's going to get the port of the thing.
You already have the port.
Oh, you already have your port?
Yeah, we would be able to use the port, and the pill, of course, would be orally administered. And that one could be done locally.
Okay.
And it's not something that you have to make a decision today by any means. The one I would say caveat is with your insurance, if you go the route of the IV and the pill, I can't see you and administer that treatment here because your insurance won't cover seeing us here. It only covers for the advanced treatment options like the inpatient hospitalization and so forth. So it would be with your local oncologist. But you can also, if you're not satisfied with your local oncologist and you wanted to establish with another doctor, I can certainly try to link you up with someone that I have experience working with. That, you know, I would say that we just need to make sure they take your insurance.
Okay.
Well, thank you.
Sure.
All right.
Time and details.
Would it be helpful if you had maybe some teaching sheets to be able to review for the chemotherapy pill and the IV medicine?
Yes.
Just so you had something to take home?
Yes.
Okay, perfect. I can work on that.
Okay.
And if there's interest, I can also give you the consent form for the clinical trial, but if it's something you're not interested in, then I'll save the paper. I'm not offended, by the way. It's completely an individual decision. I want what's best for you, and I want you to start feeling better. So whatever avenue we get to that, I'm happy.
Yes. Okay.
Do
Okay.
you want to take the consent home, or you're not interested in hospital stay?
I'm not interested in the hospital stay.
Perfectly
I can't,
reasonable.
you know, unfortunately, I can't
No. I don't think that's a wrong
be
thing
in a
at all.
hospital. Yeah.
Absolutely, yeah. So let me do this. I want to step out, and then I'll be able to print out those things, and then I'll come back in, and then I can give your local oncologist tomorrow a call, and let her know about everything that's kind of transpired since I had talked with her last in November, and where we are with things, what the biopsy showed, and my treatment recommendations, and then they can get things rolling there. And then, I would just be on the lookout for a phone call from them about, when can we get things set up.
Okay.
Can you send lab results from today to the primary care doctor?
Yes, certainly. And additionally to the oncologist
course.
as well. Yes, absolutely.
Okay.
Let me, in fact, it's easier if I do it on my phone.